We're recording.
Thank you for everyone to coming to this event, Bristol Psychiatrist Society's first event. I want to thank all of the speakers as well for taking the time out of their day to come and join this event. It's basically just for anyone who's interested in psychiatry or has a special interest, just wants to know what psychiatry is about. We're just going to talk about how to get into this specialty and different specializations that you can go into after psychiatry. So yeah, then Vijita, do you want to?
Yeah, so we've got Liaison Psychiatry, Old Age Psychiatry, Forensic, Perinatal and Substance Misuse. So we'll have a chat for like 15 minutes on each sort of thing, and then if any people have questions at the end of each talk, then they can feel free to pipe up, unmute, or just type it into the chat. If everyone could stay muted throughout the whole time, that would be good, and then just unmute yourself if you have a question so that we don't get any interference. I'm Rajita and that was Sharon. We're the co-presidents of the Bristol Psychiatry Society. So we have Dr. Abby, who's our liaison and old age psychiatrist, and Dr. Aslanyan, who's our forensic psychiatrist, Dr. Gupta, who's our perinatal psychiatrist, and Dr. Cross, who's our substance misuse psychiatrist. So without further ado, Dr. Abby can take it away.
Right, I'm just going to share my screen. So you should all be able to see that now.
Yeah.
So liaison psychiatry, it's quite a young specialty. And I remember when I first told my dad that I was going into liaison psychiatry, he looked at me strangely and said, but surely liaising with people is just what all psychiatrists do. And I then had to rethink, actually, perhaps the title doesn't mean a great deal to people who aren't in medicine or aren't psychiatrists. So liaison psychiatrists are people who liaise with other doctors, basically, not GPs, because we all liaise with them. But a liaison psychiatrist is a psychiatrist who is embedded within the acute trust. And what kind of things do we see? Well, we see everything, and I mean literally everything. I think there's a few too many people for me to ask for just like examples of what we see, but we see anything from eating disorders to self-harm to medically unexplained symptoms to the person with a really well-controlled schizophrenia who's on clozapine who breaks their leg, and then you end up having to sort out some really complicated drug regimes with your medical colleagues. And the case I've chosen today really illustrates very well the beauty of being able to be that liaison between the mental health world and the physical health world, because sometimes for each side it can seem like here be dragons. You both talk different languages sometimes. The physicians have very little idea of the legal constraints under which we operate, and sometimes the psychiatrists have been out of physical health care for such a long time that we don't necessarily understand the constraints that the physicians are operating under. Neither side seems to know for definite exactly what can be done in each hospital, and we all protect our boundaries. So you need to be a great diplomat as a liaison psychiatrist, because you are talking to often quite senior management in both mental health and physical health trusts, and trying to find common ground between them so that your patients get a good deal for both their mental health and their physical health. So I'm going to show you a case which illustrates quite nicely why liaison is so interesting. And this is of a gentleman he's a 64-year-old man, and he has a long history of bipolar disorder, for which he's been taking lithium for a long time. Unfortunately, the lithium has a side effect that if you do take it for a very long time, it can damage your kidneys. And sure enough, after 2 or 3 decades on lithium, he's got renal failure. Now, the renal failure was so severe that he wasn't able to continue on the lithium, but that was okay. The mental health team looking after him switched him to valproate, and he continued to be well controlled on that, until his renal failure became so severe that he needed to start dialysis. And within a few weeks of starting dialysis, he had relapsed into a more severe manic episode than he had ever had before. He was admitted to the local working age adult mental health hospital. And while he was there, he was so unwell that they couldn't actually get him across to Gloucester Royal for his dialysis. So we're then faced with a patient who is not only mentally unwell, but physically unwell. He was transferred to Gloucester Royal, but even they couldn't control his mental illness enough for him to have dialysis. So we're faced with a man that the mental health hospital can't manage his physical disorder. The physical hospital can't manage his mental disorder, and his mental and physical disorder are preventing the treatment of each one. By the time I saw him, people had started to talk about the fact that if we couldn't dialyse him, then he was going to end up palliated. And he had not had any dialysis for nearly 2 weeks. So in the end, what we had to do was inject him with a kind of a medium-acting antipsychotic called Clopixol twice, plus a quite high dose of benzodiazepines using lorazepam, such that we were able to sedate him enough to get him dialysed and then get him across to the mental health hospital, where we had to keep going with high dose antipsychotic medications until he was calm enough to be able to engage with us and negotiate. Now, the really, really interesting thing about this man, and that's just a rundown of the case, is that it turns out dialysis removes your valproate. And one of the really interesting things about liaison psychiatry is that you get the opportunity to look into random weirdnesses like that and learn about how the interaction between the mental and physical disorder happens, how we can manage it. And as a result of managing it, this man is now rehabilitating, and we're hoping that he will be going home within the next couple of months. So that's, I think, a case of a really good illustration of the interface between the mental and physical disorder and how only a liaison psychiatrist could have sorted that case out, because it needs somebody with expertise in both camps. The other group that can be really interesting are the group with the medically unexplained symptoms, but they tend to be patients who are almost in disgrace because they've been through so many different specialities in the general hospital with no reason for their symptoms being found. And what they need is for somebody to take the time to sit down with them and unpick exactly what's happened. And for some of them, we can work out a way forward which allows them to live with their symptoms and sometimes even find a treatable mental health condition, which, if they're prepared to engage with that, can make a real difference to their lives. There's also been a lot of work with liaison psychiatry done with long-term physical disorder, such as diabetes and other long-term conditions, that actually, if you engage with people on a mental health level, then you can improve their symptom control, their medication compliance, and their feeling of being in control of their illness, and therefore improve their physical outcomes. So that's what I think are the most exciting things of liaison psychiatry. You tend to not be able to go into liaison psychiatry until about CT3, but it depends on where you train. It is a postgraduate specialty in many ways, in that you need to do your MRC psych first, because it is a more complicated specialty. It's not something that you train in by itself. You would get an endorsement in liaison psychiatry while getting your training in general adult psychiatry at the moment. So you would need to do at least one of your placements with liaison with a trainer who is allowed to, who has the qualifications to give you an endorsement. All right. Having said that, I've been in liaison such a long time that it wasn't a thing by itself when I started doing it. So I don't actually have an endorsement in liaison. I just did it because that was what you did. But that was 10 years ago. These days you need an endorsement, really, if you want to go into liaison. So that's something to think about while you're doing your core training and planning what jobs you're going to do as a higher trainee. Now, are there any questions? I'm aware that it's just nearly 6:10, so hopefully that should leave us 5 minutes for questions about liaison psychiatry.
Thank you so much, Dr. Abby. I don't know if anyone wants to pop any questions into the chat, or they can unmute themselves and speak up. If not, I have a question ready to go. I'll start with my question. How easy did you find it going into other medical wards and being able to work with the team like effectively when you were like flitting between the places that you had to go? Because I can imagine going to a completely new setting sometimes can be quite difficult to try and engage with the team that's there.
If you're a shy individual, this is probably not for you. You do need to be a fairly confident individual.
Yeah.
You need to have a thick skin because of all the management input that you need to have, because there is a bit of a tendency amongst our physical health colleagues to what they want from a liaison psychiatrist is a psychiatrist with a net and a white van to take the patients away. Mm-hmm. They don't want us to help them manage the patients in their hospital. They want us to just take them away. And in some ways, you know, they're very, very busy, but there are so many people with a mental disorder in their hospital that we physically cannot do that except for the most ill. So what is helpful and what we have a lot to do with as well is an educational component, in that what we're trying to do is teach them how to manage their mental disorder patients better.
Yeah.
Yeah.
We've got a question in the chat from Trayvon. Do you feel you have a solid understanding of general medicine, or is it more niche topics such as valproate and dialysis?
I think it would be fair to say that I wouldn't be able to function as a consultant physician. I think that would be very, very fair. However, I do feel that I have kept on top of more of the physical health knowledge than a lot of my consultant psychiatry colleagues. I'm also an old age psychiatrist, and they tend to as well, simply because older people tend to be more frail and have more comorbidities. As with all specialties, if you're not doing something all the time, you do tend to become less up to date with it. But I think it is fair to say that in general, liaison psychiatrists know more general medicine than other psychiatrists, with apologies to my psychiatrist colleagues.
Perfect. There aren't any more questions in the chat, so we could get going to old age psychiatry if you'd like, okay. Dr. Abby.
Right. So, sorry, I'm just having to get back to where I can see the slides. So, I'm also an old age psychiatrist, my other job. And old age psychiatry is another interesting topic from an interface between physical ill health and mental. And that is because so much of what older people experience is inextricably linked to their physical health, whether it's because they have lost a lot of things as they get older. Once by the time you are 80, you are no longer working, so you have lost your role. Some of your friends may have died, your spouse may have died, you may have lost your mobility, you may have lost other bits of your health, you may have lost other things that you used to do that were really important to you. You may no longer be able to, you know, to run fast or to swim fast. You may no longer be able to drive. So you've lost a lot of things. Therefore, perhaps you are more we know you are more likely to become mentally unwell. So we see a variety. We see serious mental illness and we see less serious mental illness. We see it in the context of the robust older people who are still, you know, walking 4 or 5 miles a day, even when they're 80. We see it in the context of the really frail older people who are on like 2 pages of physical health drugs, can't walk, you know, may need oxygen piped. But we also see those people who have any kind of cognitive impairment. And for most old age services, we see the cognitive impairments no matter how old they are. So if your memory is the thing which is a problem, you won't get referred to to a working age psychiatry service. You will get referred to the memory service, which is part of the old age team, even if you are 55. And young onset dementia is a very specific subset of the memory impairment service. So we see everything that working age adults see, but we also see memory. And memory clinics are big business in old age psychiatry. There's a number of different things which can make your memory start to fail you. So we need to be able to do, as we would do in any other physical disorder, we need to get a history from the patient, those around them. We think about what imaging we may need to do. And actually a lot of old age psychiatrists can look at brain scans and interpret them. Probably not as well as a radiologist, but they can certainly spot a shrunken hippocampus on a CT scan. We would then do some cognitive testing, make a diagnosis, and enable that person by putting in an appropriate management strategy to carry on living independently as long as they can, by working with voluntary sectors, social services, and with our physical health colleagues and GPs. So there's a lot of interesting things I find about old age psychiatry, but the main thing is that the people that you see have lived such interesting lives. They have experienced such a lot because they have been around for such a long time. And I must admit, that's why I find it interesting, is because the people are so interesting. So if you are generally a person who likes stories, who likes to try and unpick a long and interesting life, then old age psychiatry could well be for you. If you're a person who fears that you will lose the ability to do a lot of your general medicine, then again, old age psychiatry can also be for you, because there's a lot of geriatric medicine within old age psychiatry, and in some ways just as much as there is in liaison psychiatry. So the other reason it's really important to think about serious mental illness in the context of older people is that if you get ill mentally when you're old, it makes you more likely to get ill physically. If you don't look after yourself when you're old, the consequences are likely to be more severe than if you don't look after yourself when you're young. Also, people are perhaps less likely to notice, because a lot of older people are more isolated, so they're not necessarily going to be visited very often. Older people are more likely to complete suicides because they have the means, because they are more frail, so they're more likely to kill themselves with the same act at 80 than the same act if they are 40, thinking about overdoses and things like that. And if you get, for example, depression when you're older, it makes you more likely to die. It makes you more likely to get just about every other illness you care to name. We can't actually explain that, but depression seems to make your brain more vulnerable and your body more vulnerable to all the other illnesses, perhaps because you are neglecting yourself. In particular, you're more likely to get dementia, which of course then has very far-reaching ramifications. Depression can even masquerade as dementia, and if we're not careful, people will get labelled with dementia rather than the very treatable depression. The other reason that older people are a fascinating group is that they are so much more prone to a thing called delirium. Now, hopefully you've all learned about that, and certainly liaison psychiatrists would encounter delirium as well, because it's often the mainstay of their interactions on the geriatric ward. And in fact, teaching geriatric wards how to manage delirium appropriately is one of the most effective things a liaison team can do. But it's important to pick up when something is delirium rather than depression or dementia. Delirium will resolve. If we can find its trigger, we can treat it. But if we don't catch it, then delirium, if it's left untreated, can make your dementia accelerate and can again make you less likely to be discharged from hospital into your own home, less likely to be able to continue living in your own home, and less likely to get back to your baseline of where you were before, which perhaps will make the difference between you living independently and not. The other thing to remember is that all those people that you met with schizophrenia and other serious mental illnesses when you were doing working age adult psychiatry, if you look after them and you make sure they access all the correct healthcare, they're going to eventually get older. And you need to have a group that can care for those people while still being mindful of their physical frailty as well. And old age teams are particularly well set up to do that. They're often more in touch with the social work team in the local authority, who will be able to put in packages of care more quickly if those people need them. So I've got a case presentation, a case of a person that we had in recently, just to show you how strangely sometimes diseases can present in older people. So the lady that I'm thinking about, she is 86, and she didn't have much in the way of memory impairment particularly. She was still looking after herself. She could, for example, make an apple pie unaided. But all of a sudden, in May this year, she let herself into her son's house, and when her daughter-in-law came out of the lounge to go and make a cup of tea, she grabbed the daughter from behind and beat her up quite severely. The daughter-in-law was understandably very traumatised by this. And when the police were called, the lady told them that she had become telepathic. She could hear lots of different voices telling her lots of different things. Interestingly, one of the voices she could hear was Boris Johnson's, but he never actually told her anything useful, unfortunately, so I discounted him. And unfortunately, some of the things that the voices told her was that her son had been severely hurt by his wife, her daughter-in-law, and that was why she had let herself into the son's house and had when she knew the son was out, and had seriously assaulted the daughter-in-law. So she was admitted to hospital under suction. And the interesting thing about this case is that the list of differentials is so long, because with older people, you have to consider a lot of physical causes. You have to consider whether this could be dementia. Could it simply be a psychotic illness? Well, yes, it could. So there's a lot of things that you have to investigate and exclude before you can focus on a course of action which might help this lady. And thinking about risk with older people is really interesting as well, because you might think, well, an 86-year-old, how much risk is she going to pose? Well, clearly quite a lot. If there had been other things available that she could have grabbed, or the daughter-in-law had been a bit less frail, more frail than she was, that daughter-in-law could have been very, very severely injured by this 86-year-old lady. So the risks to people and to themselves and others are still not negligible, but you also then have to bring in the risks to that potentially frail older person and think about that as well. So risk management in older people can be a lot more complex. And if you like unpicking and planning that kind of thing, then old age psychiatry could well be for you. So I'm going to stop sharing now, if I can work out how to do that. Okay. And then if there's any questions, I think we've got a few minutes left.
Perfect. Thank you, Dr. Abbey, for that.
I was just wondering, because you said that you're, with geriatrics especially, you have to consider a lot of things when it comes to the patient. You have to rule out a lot. Does that mean, do you guys work very closely with other members of other specialties as well?
We tend to work really closely with the GPs, and we would certainly expect a lot more physical investigations to have been done before a referral gets made to us, if that's possible. With the lady I've just presented, it wasn't possible because she presented so acutely. So when she was admitted to hospital, we have done a battery of blood tests, considered whether imaging was needed for her, and in fact the imaging was done but didn't show anything desperately exciting. So we consult with our neurology colleagues quite a lot. We consult with our geriatric medicine colleagues quite a lot, in order to try to unpick what could be going on. We're very lucky in Chelton Lane Hospital. We have GPs that visit the hospital every day as well. to try and help us care for the more long-standing physical illness. I can see there's lots of questions popping up. There was one about charity work. I'm trying to think where I can see the chat. There we go. Aha.
I think Joe is asking, is there much opportunity for charity work in psychiatry?
To be honest, as much as there is in any other branch of medicine, the volunteer work that I have done has been for things like teaching adult social care about the Mental Capacity Act. I'm vulnerable adults lead at my local church, and I wouldn't have been asked to do that if I wasn't a consultant psychiatrist. So there are opportunities for charity work. If you're thinking about things like Médecins Sans Frontières or things like that, I don't know, I'm afraid, possibly less so than there would be in other medical specialties. And then I can see Isabel said, at what point in your training can you decide to go into old age psychiatry? So it tends to be something that you have to have some idea about before you go into higher training. So your core training for psychiatry is 3 years long. And by the time you're a CT3, you're probably taking the final part of your MRC Psych examinations, and you need to decide which kind of higher specialist training you're going to apply for. I am actually dual trained, so I've got working age and old age accreditation, and that was a 4-year higher training in order to get both. But usually if you do 3-year higher training, you would do 2 years in older age and 1 year in working age. And but most working age trainees would do 1 year in old age potentially, or can choose to do that. So with most of these subspecialties, you need to decide at the point that you're applying for to be a higher trainee. And then between the two subspecialties, it went from half and half a few years ago to I was a completely liaison psychiatrist for a while, and then for the last few years I've just done 1 session of liaison per week to fill a gap that they couldn't fill and have the rest of my time in old age. So I started doing liaison about 10 years ago, and initially it was almost half and half, but like I said, then went completely. But it is possible to have a job which is split, not if you want an easy life though.
Perfect. Oh, I think Izzy's also just asked, which of your specialties do you prefer?
It's an interesting one. My main job at the moment is on the dementia ward, which is essentially a palliative care ward. And if I have to say, at the moment, I've discovered I have quite an affinity for palliative care. We work quite closely with the palliative care doctors. We end up having patients undergoing end-of-life care about 8 to 10 times a year, even without COVID. So I like a mixture of the two. Liaison is, I have to be honest, liaison is more tiring, and liaison will take up as much time as you can give it. There is no end to it. There is always more that can be done in an acute hospital. So you just have to finish what you can do and draw a line under it eventually at the end of the day. So I'm very glad I've done liaison, but as I've got older, I have found that old age is, I think, preferable, particularly as my children are needing more of my time.
She says thank you.
Yes, thank you.
Thank you so much for speaking to us, Dr. Abbey. That was really informative. I hope you've inspired some budding old age psychiatrists or liaison psychiatrists.
I'm very, very happy to answer email queries if people are too shy to ask them now or think of something later. So Regita, if you need to refer any questions on, then I'm very happy to do that.
Lovely, yeah. I can pop your email in the chat at the end or something.
Yeah, no problem. Thank you.
Perfect. Thank you so much. Okay, so next up we have Dr. Gupta, if she's around. Yes. And she's our resident perinatal psychiatrist. So whenever you're ready, feel free to take it away.
Can you see this?
Yes.
Just going to try to start the slideshow. Yes. Is that okay?
Yeah, perfect. Yeah, we can see that.
Right. Good evening, everyone. First of all, thank you to Rijita and Sharon for setting this up. And it's interesting. And as Rijita was saying earlier on, it would have been a more speed dating session, which would have been even more interesting. But anyway, I always love having sessions like this where I can bring my love for perinatal to an audience. So that's nice. So now, I'm a perinatal psychiatrist and I work for the Essex Perinatal Mental Health Services. And I work actually in both the community and as a consultant running an inpatient mother and baby unit. Now, before I go into the who, why, the who, why, when, where, and how of perinatal mental health, I will take you through my journey and how I reached where I am now. So I trained in India. I completed my undergraduate medical training from India. And when I was choosing my higher training, my specialty, I actually was torn between obstetrics, which was the expected thing to do back in the 80s when I completed my training, or psychiatry, which was actually my love. And maybe that love came from my father, who is actually a psychiatrist. So ultimately, unfortunately, obstetrics won, but I don't regret that. And then I completed my higher training in obstetrics. And I've actually worked for about 18 years in obstetrics before I ventured and retrained in psychiatry. Now, after my stint in India, I then had an opportunity to go to the Middle East in the Sultanate of Oman, where I worked in obstetrics again. But that is the place I was introduced to perinatal mental health for the first time on 2 separate occasions. The first occasion was, I must say it's quite embarrassing when I talk about it now. It was when I was sitting in an antenatal clinic looking at a patient, reviewing a patient who was a 15th gravid. So she was gravid at 15, had 14 other children, but in the side, it was written in brackets, she killed 5 of her children under the influence of gin. Now, I looked at that. I thought of it as saying that, yes, women in this side of the world don't drink gin. So what is this all about? And then I just did not pay much attention to it. Now, retrospectively, obviously, I know that that must have been a woman who suffered from postpartum psychosis, and there must have been some infanticide involved there. So that was my first opportunity. The second was, I then came across a series of articles written by Margaret Oates, who is still a very well-renowned perinatal psychiatrist in England, and who is one of the, I would say, people who set up these services in this country. And then I presented her articles in a National Woman and Child program, which was organized by the WHO there. And then I came to England, and there I realized I have to start from scratch again, no matter where I was in my career. And that's when I decided to go back and retrain in psychiatry. I finished my core training, did my higher training in general adult, and then I was again introduced back into the world of perinatal mental health. And that's where I moved on. And it made sense now because I had done 16 years of obstetrics. It made sense to go into perinatal mental health. But that doesn't mean you have to do obstetrics to understand perinatal mental health and what it is all about. So just a little about what we do. So what is our service? So as Dr. Emma just mentioned, we are also a relatively newer service. England has seen a boom in perinatal services in the last, I would say, 4 or 5 years. I mean, I think we are one of the very few specialities where the government has invested quite a lot of money to develop the services. And I'll tell you a little about that. So we are a specialist services working with women when they're pregnant and have mental health issues, or after they've given birth. And the new criteria is going to be working with them up to 2 years after they've given birth, whereas just recently, up to recently, we were working for just up to 1 year. Now, outside the pregnancy and postpartum period, we also provide preconception counseling. So we do give preconception advice to women who may have a mental health problem and who are now planning a baby because they might be on medication and they want to make sure that whatever they're taking, they can take during pregnancy. Now, one of the main problems of perinatal mental health is the fact that treating these women can be difficult because, as you know, You do not have RCTs to tell you about what medication is good for a woman, what medication is not good for a woman, especially during pregnancy, what could harm the baby and all. So we just have to depend on our own experience and whatever evidence we can gather through case studies. But I think, like I said, it's been many years now since this specialty was developed more, so we do have a lot of information. The other nice thing about perinatal mental health is the fact that we are not just treating a woman, we are actually helping her family. And the infant is very much in the picture, whether the infant is unborn, whether the infant is there in his mom's arms. So that is what is, and why it's rewarding, I will tell you after I talk about my case. Now, when are we? Like I said, perinatal mental health, even though it's a new specialty, historically it goes back right up to 400 BC when Hippocrates actually even talked about what appears to be a postpartum psychosis when he wrote about women suffering from postpartum delirium. And since then, lots of scientists and physicians have had, documented about perinatal mental health, as you can see, Felix Plater and others too. So there's a lot of documentation there, but I think a lot of it was understood as witchcraft. And, there was Esquirol who talked about, it was an illness that was caused by women's suppression of her milk. Marseille talked about has also talked about symptoms. Some people talked about it being an unresolved Oedipus complex, etc. So obviously, and then things moved into this current era where we have a much better understanding. This was a nice post. I thought I'll just bring it here in 1919, where it was very clearly recognized that a woman while pregnant should remain calm, sweet-tempered and happy, because if she was to worry or be angry, then it could affect the baby and affect mother's blood, which supplies his food, which is actually quite relevant. So why has so much money been invested? Why are we so important as a service? One of the main reasons is what the risks of untreated illness. Now, an untreated mother who is currently pregnant or who has just given birth, there's a huge impact on not only herself, the increase in morbidity, the increase in mortality, but also an impact on the infant and on the wider family. Suicide is one of the leading causes of maternal deaths, which you might be hearing, and gradually more and more every year in confidential inquiries, you understand that suicide is one of the causes of pregnant women or postpartum women dying. Infanticide, women, when they have a postpartum psychosis, they are known to kill their children. I'll talk to you about a few cases in a minute about that. Breakdown of childcare, lots of children are taken into custody. It has a significant impact on the breakdown of a family unit. And there's also increase in domestic violence. It has a significant impact on the infant, and to summarize it, it impacts on both the biological, psychological, and social, it leads to all these three problems for a child. This just shows that children who were seen to be depressed at 16 all had mothers who were depressed, mainly during pregnancy, which is quite a telling thing, isn't it? And another thing is, look at this. This is a woman has a highest incidence of having, becoming psychotic during the first few weeks after she has given birth. And the psychosis that happens at this time is slightly different from the psychosis that happens at any other time, because it's very sudden, very severe. But the good thing is that if it's caught in time and treated in time, the outcomes are very good. Women don't come to us, so that's why a specialist service helps very sensitively try and draw in women, because I think at this stage, when a pregnant woman becomes depressed, she's too scared to talk about her depression, because she thinks that my child will be taken away from me. How can I be depressed when I'm supposed to be very happy at this time? So, it's a very, very difficult time, which has to be treated very sensitively and with a lot of, support and all. Now, I was just mentioned about the suicide, and I just thought I'd bring up very quickly a few tragic stories. Now, this is a lady, Charlotte Bevan, who actually delivered, I think she was your side, Bristol side, was she? She gave birth, she had schizophrenia, she gave birth, and just a couple of days after, she just walked out of the maternity unit and took herself and a baby to the bridge and jumped from there and killed herself. And one of the main things that came up in the coroner's inquest was the fact that she, there wasn't a good plan, and maternity services should have been informed that, you know, she was unwell and there was a high risk of relapse. Now, this is a consultant psychiatrist. Her name was Daksha Empson. She is one of the reasons why we have perinatal services in England. She was a consultant in the North East London Foundation Trust. She had a bipolar illness and she gave birth to her daughter Freya. And 3 months after Freya's birth, was it 3 weeks after? So very soon after Freya's birth, she killed both herself and her child. And this was because she became very unwell, but did not seek help, again, because of the stigma and that she may lose her job, that she will not be able to work as a psychiatrist after she does. And since then, a lot of support is being given to even the professionals who suffer from mental health problems. This is another woman who killed her 3 children. And finally, this is a very famous woman in America, Andrea Yates, who killed all 5 of her children because she was depressed in one go. But unfortunately, in America, the rules are different. So this woman had to go to prison. And it is only after this, you know, the hard work of her solicitor who has managed to bring her to a mental health facility where she may spend the rest of her days, but at least she is in a more appropriate place. Whereas in England, I think women are given help and support in a mental health facility because it's recognized more. And these are the confidential inquiries that just show you about the suicide into maternal, in maternity, post-delivery and all. And again, this is the same thing. It's the maximum cause of death. The other reason is that it's also quite a big burden economically. Now, this is not the main reason, but obviously when it was seen, there was quite a high economic burden seen with untreated mental health problems during pregnancy. And one of the main reasons, the other reason, which I forgot to mention earlier, is the fact that children who have had unwell mothers, who have grown up in a family where the mother was unwell when they were pregnant with them or postpartum, they also grow up to have mental health problems, and their children grow up. So there's a transgenerational impact also. Now, mental health problems, all mental health problems are seen during pregnancy and postpartum, right from the milder ones, the adjustment disorders and distress, up to the postpartum psychosis, which is a very severe illness. And again, I've just divided them into some which are pre-existing. So many women go into pregnancy with pre-existing mental health problems, and some have a new onset of them. Now, sorry, this is just, so what do we do? So like I said, we have community services and we have inpatient mother and baby units. This is a very complicated diagram, but it just looked nice. So I brought it to you. This just shows how, when patients are referred, what sort of services we provide, what do we do, how we support them. As you can see from here, women with severe mental illnesses, we make sure that we work very closely with all the other services involved to set up pre-birth planning meetings so that everybody knows what to do. And then we support them after they've given birth. We even support them while they are on the maternity services just after they've given birth to make sure that they have a good package when they are discharged with the right support. So this is what we, work. So again, another, the good thing about perinatal is we always say psychiatry works holistically, but I think perinatal mental health more than others, these are all the services that we have to work very, very closely with, because we have maternity services. We even have midwives who are specialists in mental health, who work closely with us. They can identify women at the point of booking who have mental health problems and then refer to us for further help and support. We have to work with psychology. We even work with third sector organizations, primary care, substance misuse services, health visiting, and obviously social care services. Now, I just thought I'll take you a little, so we have community services all throughout England now. We are the only country in the world where perinatal services are so developed that every area has at least a community mental health service where women can be seen and referred. But we are also the only country in the world that has around 19 specialist mother and baby inpatient units. And these are where the inpatient units are all throughout. But we still don't have enough. So we have about 161 specialized beds. Now, the advantages in how these inpatient units are different from the other units is that here we treat women with acute mental illnesses, but they come in with their child, because we also help a woman continue to bond with her child and develop a good bond with the child, because that is what is the crux of the problem and the impact it has on the infant. So it's important that we treat them together. So they come into this unit with their mom and are supported while the mom is getting better. And this is a picture of our unit, just to tell you, it's a very nice place, very unlike other generic general adult, hospital inpatient units. Every woman, and this wall here is a wall of hope, as our patients call it. They put their handprint and the baby's handprint or footprint on the wall, just at the point of discharge. And I think for other patients who come, it just gives them hope that they will be discharged soon too. And obviously we have all the toys and everything, changing mats. So it's a very nice homely environment. I just thought I'd quickly just outline, I don't know how much time I have left, but I'll just quickly go through a case study. Is that okay? So
yeah, that's fine. Yeah, go ahead.
Okay, so this is a 25-year-old woman who gave birth to her son, and her son was around 2 days old when she developed very, she presented with an odd affect and behavior and irritability. Now, this was while she was on the maternity unit after giving birth. She had no previous mental health history. There was no family history of mental health problems. She was a very high functioning woman who was actually the chief executive of a company and had about 300 to 400 employees under her. So when she started presenting with an odd affect, there was some discussion as to what is happening here. But then when she was reviewed by maybe one of the doctors on the maternity services, she was well. And so they did not think much about it. Then a couple of days passed. Then what happened was that she then became extremely unwell. This all happened within the span of 24 hours. She became so unwell, she was stripping herself of her clothes, she was running around, very agitated, she was responding to auditory hallucinations, and it looked as if she was also experiencing visual hallucinations. And so she was assessed under the Mental Health Act because she had lost capacity, and she was admitted to our mother and baby unit. And at the point of admission, she was refusing treatment and continued to deteriorate in the next 24 hours, where she had to be restrained, unfortunately, and had to be given intramuscular injection. But then she, after calming down a bit, she then accepted treatment and continued, though she continued to present with excitability and manic-like behaviors. She used to sit at the door and sing out loud for the patients on the other side of the door in another ward, and just saying, I'm just entertaining them. So she was quite manic in her presentation. She had to be nursed one-on-one, and her baby was cared for in the nursery in the beginning because she was not considered safe enough to look after her baby for the first few days. She was started on antipsychotic treatment, and though she showed some improvement, she did not fully improve. And then lithium, which you might be aware is a mood stabilizer, was added to her treatment regime. And following lithium addition, she improved so much that she was very soon, fit enough to be discharged home. And she was then discharged into the care of the community perinatal mental health team, who then continued to review her. I actually saw her in the community also, and she engaged well with the services, improved, was able to look after her son. And then she, improved well enough for us to discharge her back to her GP on some medication. Her final diagnosis was a bipolar affective disorder, but 2 years later, she was keen to have another baby. So she came to us for preconception counseling. She was on medication and we had a very good discussion with her as to what would be good. But our main aim at that time was to ensure that she remains well this time round, or at least we reduce the risks, because the risks were very high of another relapse, which she didn't want. And we did that. And we continued her on some antipsychotic medication throughout her pregnancy. She gave birth. We provided a lot of intensive care, weekly, bi-weekly reviews of her after she had given birth. And she increased her medication even after she gave birth, and she actually remained well. So it was a big sigh of relief. She is now, I just saw her 2 days back. She is now 7 weeks postpartum, and both she and her husband are so happy that this time round she was able to, you know, go through her pregnancy without any relapse of her mental health. So this just gives you a little understanding. Like I said, I mean, the main satisfaction which I have derived from perinatal mental health is the fact that these women are very unwell when they first come to us, but they can get very well and they can go back and function in a very similar way to what they were doing before they became unwell. They are able to manage their families. So, you know, that smile that a mom gives to her baby and the baby gives to her mom is what brings in the most satisfaction. So, and this is just some feedback from some of the patients that we've supported. And I would be more than happy to take questions. And obviously I've put my email address here for anybody who would like to talk to me about perinatal mental health afterwards.
Thank you so much, Dr. Gupta. That case is really, really nice to see that it all panned out in the end really well. As ever, if anyone has any questions, they can feel free to put it on the chat. But I have one just to start us off. In terms of mothers experiencing like a psychotic episode or having some difficulties with their mental health, how common is it for that to happen with mothers when they've not had any issues with their mental health before, or have not experienced any sort of psychosis or anything?
I mean, obviously there's varying percentages of each of the mental illnesses. Yeah. Postpartum psychosis is the most severe, but the most rare. So the current evidence shows that at least 1 to 2, if not more, women without any previous history of mental health problems are at a risk of having a postpartum psychotic episode after they've given birth. 1 to 2 per 1,000. Yeah. That is women who have given birth. So yeah, it is not so common, but it is very severe and it is treatable. So that's why, you know, it's good to know. Whereas other things, I mean, 1 in 4 women who have given birth will present with some form of mental illness. It is that high. But obviously psychosis is less common. Postnatal depression, pregnancy, depression in pregnancy also is very common. People used to think pregnancy was protective, but it's no longer the same way. I mean, there are the same number of women who are depressed during pregnancy as they are after they've given birth. Anxiety disorders, obsessive compulsive disorder is another interesting illness, which is there is a perinatal OCD. So women are very prone and at a high risk of having obsessive compulsive disorder after they've given birth, even though they may not have showed any signs of symptoms before that.
Yeah.
I think we've got some questions on the chat. Isabel's asking, are there many children that end up in care as a result of mother's mental health?
I would not like to use the word many, because I think one of the main things that we would like to do, but yes, there are children that do end up in care. And sometimes, because children's social services work slightly differently from us, we are constantly trying to still work together. We are trying hard to keep a mum as well as possible. And they obviously, that is what their ultimate aim is, to keep a mum and child together. But sometimes, unfortunately, it doesn't happen. And for many, many reasons. Not just mum's mental health, but it could be other social and psychological reasons that prevents a mum from caring for her baby. So I wouldn't be able to tell you the exact percentage of how many people, children go into care, but yes.
Edward has asked, do you provide care for new fathers with poor mental health, not just mothers, or are they treated with other psychiatrists instead?
No, now with the recent changes in our services, we are going to be we've always support fathers. So even on the inpatient unit that I am the consultant for, we always engage fathers in every meeting for mums and ask fathers how they feel and give them information on how this could impact on them. We had already been doing that, but now we are going to be offering them assessments. And following an assessment, if we feel that they need further help and support, we will then signpost them to the appropriate services. And if you want to look, there's a lot of fathers out there who have actually talked a lot about how isolated they feel when their partners have experienced mental health problems, and how they felt that every focus was on them, on the partner, and people were ignoring the dads. But I think we try our best not to. But like I said, I mean, now we're going to be assessing them also. That'll be a part of our service.
Okay. And go ahead, Sharon.
Katie's asked, have you seen any cases of pregnancy affecting those with eating disorders who may have previously recovered?
Sorry, have I seen anything? Eating disorders, pregnancy with eating disorder.
Yeah.
Oh yes, a lot. Eating disorder is a very interesting illness. Now, as you know, eating disorder outside pregnancy can be very severe, can be pretty bad. And it's mostly related to control. In pregnancy, sometimes in some situations, I've seen the eating disorder to actually improve. The reason being is that a patient feels that pregnancy is not in her control. So even if she's putting on weight, that is not something that she can control. So she is able to accept it, though then you might see a relapse after she's given birth. But then there can be a group of women who would relapse just because of the fact that pregnancy makes them bigger. So they cannot really accept that at all. So we have had patients admitted to the inpatient unit also, but things do get better. I mean, with the right amount of support with eating disorder services, with the right psychology, they do. Yeah, things can get better, definitely.
And finally, Lauren has asked, what sort of services are provided by the community mental health team for mothers that are discharged?
Discharged from the mother and baby unit, is that right?
Yeah, I think so. What sort of services do the community mental health team provide?
Community mental health services provide very similar services to what other community mental health teams provide. They're just more intensive and they are more focused. So we can have nursing staff who go over there, review the mental health. We'll have doctors who are reviewing the mental health and the treatment plan. We can have nursery nurses who are actually helping the mother develop the bond and look after the baby and advise the mom how they can, care for their baby. We have psychology, and we also have another separate service, which in Essex, it's called Together with Baby, which is actually providing parent-infant psychology. Now, parent-infant psychology is a very interesting area where psychology is actually provided to both the mom and the infant. And people have asked us, how can a 2-day-old infant get psychology input? But when you read about it, it does help. So it helps. There are things like video interactive guidance where you take videos of a mom working, with the baby, playing with the baby, highlight all the positive aspects of it so that the mom is able to gain more confidence in how she's caring for baby. We also provide groups, we provide, group therapy or other sort of group activities to mums after they've discharged. So there's a wide variety of services that we can provide to them. And obviously fathers support.
Perfect. I think that's all the questions that we've got written down. Thank you so much, Dr. Gupta, for speaking to us. It's been really, really interesting to hear about perinatal psychiatry. I think it's such an emerging field, so it's quite nice to hear all the services and how it's kind of expanding at the moment.
So thank you. I think I ran well beyond my time.
No, that's okay.
I think we have substance misuse with Dr. Alan Cross next.
Hello.
Hello.
Hi. let me just share. All right. Start. Okay. Where is it? There we go. Okay, hi, my name's Alan. I'm an ST6 trainee, so I'll be giving us probably slightly different perspective on working in psychiatry. I'm currently working in addictions in CNWL, and I think it's probably a career path that I'm going to choose. I've sort of come to it quite late, but I do really find it quite an interesting area of psychiatry, and one that I've not had that much experience of prior to my ST6 year. So I've got a slightly long-winded career path, which I thought I'd talk about briefly. So I got my medical degree in 1999. I did house officer jobs and SHO jobs for a couple of years, and then in 2001 I joined the GP training scheme in East London. And my first job was old age psychiatry, and I really enjoyed it. And I wasn't quite sure where I was going with my career and my life, but I was quite inspired by psychiatry. So I actually left the GP training scheme straight away and re-interviewed and switched to the East London psychiatry training scheme. So that was 2001. And I worked in East London for about 14, 15 years in the end. So by 2004, I'd completed 7 approved training SHO jobs. I left training. I was fed up with training, fed up with on-calls. It's quite different back then. You know, we'd do extremely long shifts. We could work 3 days straight without a break sometimes. So I went into staff grade associate specialist posts in East London. And I worked for an assertive outreach service, which was basically a sort of community mental health team that quite actively engaged people in the community who wouldn't engage. So sort of very sort of chronic type schizophrenia type patients. I continued in that role for a number of years. I got my membership exams in 2006. And then in 2015, after being a staff grade for many years, I moved to Sweden. My wife's Swedish. So I thought I'd take a career break at that point. I had a young child in my life as well. So I was a stay-at-home dad in Sweden for 3 years. I was doing some locum work in the UK, flying back now and again to work for East London. And then in 2018, we moved back to the UK, and I decided to complete my training. So I got onto the St Mary's training scheme, and I'm currently based in central northwest London. I'm due to get my CCT in general adult psychiatry in August this year. So looking forward to that. What interests me? So as I said, I think addictions is a very interesting area, and I currently work in Hillingdon in a generic addiction service, and also work 1 day a week for the National Club Drug Clinic, which is quite a new clinic focusing on drugs such as amphetamines, MDMA, ketamine, G drugs. I'm also quite interested in behavioural addictions. So I've done some work with the National Gambling Clinic, and they've also recently started an internet addiction service and a video gaming addiction service. I'm also interested in adult ADHD. When I was in East London as a staff grade, I was seeing lots of people coming through who didn't quite fit into certain diagnostic categories. So personality disorder, addiction, bipolar, but it was quite clear they had undiagnosed adult ADHD, but that wasn't really being picked up by many psychiatrists at the time. We're talking 7, 8 years ago. People aren't and still aren't that well trained in adult ADHD. So I sort of went and did some training and set up my own clinic. And then in my current training scheme, I did 12 months as a special interest at Northwick Park, which has an established adult ADHD clinic. So that was interesting. So I think adult ADHD is another area that I'll be sort of moving into. And ADHD and addictions go very, very well together, because about 25% of people in the waiting room in an addiction service have ADHD, either diagnosed or undiagnosed. And I'm also interested in this, which is a sort of growing area. They call it the new frontier of psychiatry. So I'm in my current special interest session, which is 1 day a week. I'm an associate research fellow with Imperial, working with Professor Nutt and Professor Linford Hughes. And these are the guys spearheading all the psychedelic research, so psilocybin, MDMA, ketamine, looking at treating disorders such as depression, PTSD, addiction, eating disorders. And I find it fascinating that drugs that can be abused are now being looked at as potential treatments. And there are very, very promising results with some of these research projects. So why psychiatry? Well, I've always been interested in how the brain works. So it's changed a lot in the last 20 years, and our understanding of mental illness is developed a lot, and particularly since functional MRI has come along and PET scanning. So in my research work, we're starting to quite understand the neuroscience behind these disorders. For example, default mode networks are a relatively recent discovery, and if you don't know about it, go and read about that one. I find psychiatry crosses over enormously with different cultures in different populations. It can be very interesting, challenging, complex work, trying to separate what's a mental illness from what's a sort of cultural belief, or perhaps more akin to religious beliefs and delusions, and where that boundary is. It's fascinating work. So it's varied work. Mental illness is very common, and there will always be work. And I think when I applied for my higher training, there was a recruitment crisis in psychiatry. I'm not sure if there still is, but it was classified as a hard to fill training post. So there was plenty of opportunity to get onto a training scheme. It's a good time to be in psychiatry, sort of increasing public awareness. It's all over the news now, mental health, and breaking down stigma. So I think it's becoming more accepted as kind of mainstream. This is a real thing, and people become mentally ill. I never really enjoyed spending time with physically unwell patients. It's true. So I think that needs no. I just didn't like being around very, very unwell, physically sick people. I enjoy talking with patients. I spend a lot more time with my patients. Obviously, there's a very holistic approach. There's social aspects to it, psychological, but also the biological, which so it's a real mix of everything, and it's a fascinating job, really. The work-life balance is good. Opportunities for private practice, telemedicine is becoming quite a thing in psychiatry since COVID. We've realised we can do a lot of our work over the internet. So I think that's something that even the Royal College are starting to think, how can we change our working practices as well? It's a wide variety of subspecialties. Do some medico-legal work, court reports. Obviously, you've got the Mental Health Act as well, which is another interesting part of what we do, which you don't have in other bits of medicine. Everyone's down to earth and nice as well, I find in mental health. Right, so you probably know this, but these are the specialities. So child and adolescent, general adult, psychotherapy, forensic, old age, LD, academic. So I'm doing a general adult CCT. And within general adult, you've got these other subspecialties. So these are the endorsable jobs that one of the previous speakers mentioned. Liaison is endorsable. Eating disorders, not, sorry, but addictions, liaison, perinatal, rehab. So you get a sort of extra little bit of qualification. So I'm in an endorsed training post for addiction. So I'll get a little endorsement at the end of my training for addictions as well. Just a very brief overview. So dependence is the mainstay of addiction. It's a brain disease. It's not just a behavior, it's not a bad habit. It can begin like that, but once it becomes a dependence syndrome, it's, you know, there are cellular changes in the brain, it is a brain disorder. It's common, it can happen to anyone. We've obviously seen much more people starting to start drinking heavily, for example, or relapsing during COVID. So this is something that's coming through now, and we're starting to see in real terms an increase in addiction. Common substances, we cover alcohol, opiates, cannabis, amphetamines, including crystal methamphetamine, cocaine, crack, previous GHB or GBL, benzos, ketamine. In the club drug clinic where I work, I see a lot of people in the gay community who are dependent on G drugs and crystal meth, and that's a very sort of specific part of addiction. And so about in the club drug clinic itself, that about 80% of the work is just on those two drugs. In the more generic sort of setting, and also in club drug, we obviously focus on detoxing people and then offering rehabilitation. So that could be done at home, in the community versus inpatient. If somebody requires inpatient, it's going to be more often than not within the private sector now, just because of the way addiction services are organised and funded. We do a lot of substitute prescribing for opiates and sort of abstinence prescribing for alcohol. We also see people with long-term opioid or benzo dependence due to being prescribed on prescription for many years, painkillers, or, you know, for anxiety or pain. So you wouldn't necessarily describe them as having an addiction, but they have a dependence, and GPs can often be reluctant to give ongoing prescriptions for, you know, for example, certain types of opiate, painkillers or diazepam. So those long-term patients tend to end up with us, and people can be on these drugs for years. So it's sort of us to try and wean them off if we can. And the psychiatrist's role is to oversee addiction assessments and prescribing, but also to assess for mental illness. And in the service I work for, it's not just people with mental illness. So it's literally a pure addiction service with a psychiatric sort of team attached to it. So not everyone's going to have depression, anxiety, ADHD, bipolar, PD, whatever. A lot of them do, but some of them purely have some kind of addiction without much comorbidity, which is quite interesting, because obviously in mental health, in psychiatry, all of your patients have a diagnosis, but in addiction, they don't all have what we would say mental illness, but they can have addiction. So I work in Hillingdon. So this is Addiction Recovery Community, Hillingdon. It's a team in Arch. I'll just give an overview of a drug service, just to give you a flavour. So Arch is a partnership service led by CNWL, together with a number of voluntary sector services. Humankind, they offer support workers. Westminster Drug Project are the forensic service, and Bob are peer support, so people who have been through addiction and now work with patients. We provide an integrated health and social care addiction treatment service. The service provides a range of addiction treatments to Hillingdon residents suffering from drug and alcohol problems and their carers. Arch is in Uxbridge, easy access for residents in the town centre. It's a one-stop shop for service users. It's a large multidisciplinary team that includes a consultant psychiatrist, specialty doctor psychiatrist, higher trainee, core trainee, FY2, nurses, psychologists, OTs, social workers, and various other recovery support workers. And service users can access the service by drop-in or be referred. So this is a specific breakdown of everything we do at Arch. So the alcohol clinic, standard and enhanced pathways. Opiate substitute prescribing clinic. So we also have needle exchange, and we test everybody for hepatitis and HIV that come through. Dual diagnosis service, so that's us, that's the psychiatry team. OTs, including personal fitness and variety of groups, horticulture, sports. A social work team, So includes access to residential rehab. So all our referrals for inpatient work, detox, rehab go through the social work team. Social work clinic focus on debt management, psychology, individual family group, DBT, criminal justice team, so people coming out of prison, lots of drug problems in prison, obviously lots of crime associated with drug use as well. Have a young people service, alcohol liaison, so links with A&E. We have a community detox team, so that's for alcohol. Access to inpatient detox for external providers, alcohol and opiates, and we have floating support and outreach. Comprehensive carers service offering a wide range of support and information for carers and family members, including group sessions affected by addiction. There's also a well-established carers steering committee and a peer support service. BOB stands for Build on Belief, one of our voluntary sector services. So this is an overview of all of the addiction services that CNWL currently manage. And it's quite a big addiction service. Not all trusts have this level. So on the right hand side, these are the two services I work for. Arch at the bottom, which is my main job. I do that 3 days a week. Club Drug Clinic I do 1 day a week, and my other day of the week is special interests, where I do my research with Imperial. I would say, as you get higher in your training, if you get an opportunity to do research, do it, because once you're not a trainee and you've never done research, you might never really have an opportunity to get into it. And it's really helped my understanding of neuroscience doing my research special interest. But on the left, so you can see that CNWL have the Club Drug Clinic, which is basically Kensington. We cover Hillingdon, Brant, Milton Keynes, Ealing, Hounslow, even Hackney in East London we have a contract with. So yeah, that's the flavour of that. And just to finish my talk, I just wanted to mention this because I think it's really interesting. It's something I wasn't particularly aware of before I did this job. And there was a good program on Netflix called The Pharmacist, which kind of covers this. But the opioid epidemic in America is huge, and it's a massive problem. So 47,000 deaths in 1 year in 2017, and 350,000 deaths in the last 20 years. 6 times the number of soldiers that died in the Vietnam War. Overdose is now the leading cause of death amongst Americans under 50. That data was pre-COVID. Overdose deaths from opioids have increased almost 6-fold in the last 20 years. The Center for Disease Control notes there were 3 waves of opioid overdose deaths in the US. So in the 1990s, oxycodone was prescribed, sometimes illegally, and that led to, that's what the Pharmacist program on Netflix is. Really interesting, you must watch it. So that led to the first spike in opioid deaths. The second started around 2010 when heroin came into the scene, and the third wave began in around 2013 when this drug called fentanyl came in. Fentanyl is a synthetic opioid. It's about 50 times stronger than heroin. And this graph on the left-hand side sort of shows a quite striking problem. So around 2000 is when the prescription medication oxycodone started being prescribed, leading to this massive increase in drug death from that drug. And there were so many people addicted to it by sort of, 2009, 2010. These people were looking for a stronger hit, so they moved on to heroin. And that's when you had this spike in heroin deaths from, 200 monthly to 1,200 a month. And then fentanyl came on the scene a couple of years later, and you can see another sort of spike. So this tells the story of the opioid epidemic in America. And there's 130 Americans die every day from an opioid overdose. So I've sort of found this very interesting, and I think it might be something I sort of develop as an interest as I progress through my career. And just to sort of compare with the UK, nowhere near as bad as the America. These on the top right hand corner, this is the GP prescribing of oxycodone and fentanyl painkillers. What this shows is that from 2008, there's been an increase in prescriptions with an increase in death rate. Okay, but we're way below the American figures. I mean, you wouldn't really call it an epidemic in the UK, but the Department of Health got onto this very quickly, and GPs sort of changed their prescribing habits very quickly once they realised the potential fatality of this. And then just finally, the drug use is rising amongst the older population. So more, look at this blue line, that's, from 93 to 2018, the highest death rate from drug overdose deaths is in the 40 to 50 age group, which I think is quite an interesting thing that we're seeing more and more older addicts coming through. So that's me. Thank you. Let me stop sharing. Why can't I stop sharing? There we go. Still there?
There should be a button at the top, I think.
Right.
There we go.
There we go.
Perfect. Thank you so much, Dr. Cross. That was really interesting.
You're welcome.
Does anyone have any questions? Yeah. I do have one. I was just wondering, do you think there's any particular reason prescriptions started increasing for the opioids within the UK, and I guess the US as well, but mainly in the UK, why GPs would have been increasing?
I think it was just, I don't know the exact answer to that, but I think it was just an offshoot of what was going on in America.
Yeah.
But over here, obviously, they jumped on it quickly. I know I've talked about Netflix, but this program, The Pharmacist, I don't know if anyone's seen it, but there were the prescribing in America was done by organized crime. So there were groups of criminals that had a doctor involved who were just prescribing these, basically dealing.
Oh wow, yeah.
And it happened in various places across America in conjunction with the regular prescribing. But the pharmacist program clearly demonstrates that that's what sort of sparked the epidemic.
Yeah, sort of drove it. Yeah.
Yeah.
Oh yeah, go.
No, it's okay. Go ahead.
So we have a question on the chat that says, if psychedelics do become legalized, what role do you see psychiatrists playing in its clinical application?
Yeah, very interesting question. Word on the streets is that within 5 years, we'll be looking at NHS psychedelic therapy clinics. So psilocybin's the main drug that's gone through trials. It's had very successful results. So, I mean, legalized, it's already legal in certain settings, so in research settings. Obviously, the problem is getting it out into a more clinical application. So when basically people the way they envisage this is that there'll be clinics set up and patients will attend for a number of sessions. Yeah. I mean, the mainstay of psychedelic therapy is psychotherapy. So the trials tend to do maybe 8 sessions, but 2 of those sessions, the participant will take a psychedelic drug and have that psychedelic experience, and then either side of that will be psychotherapy. So it's envisaged that people will turn up to these clinics, have their psychotherapy, have their 2 sessions. The course of treatment will probably last about 3 months, maybe a bit longer. Yeah, but the therapy itself is guided therapy. So person, you know, is in a nice room with, you know, good ambience, music, low lighting, all of this nice, you know, a very nice setting. And basically the person trips, and there are one or two, usually two therapists who are just in the room, just as guides, should, you know, if they need it, but they just let the person get on with it, and then the work is done following the experience, the next session and thereafter. It's definitely coming. It will happen. It's being fast-tracked in America because the results are so promising. Obviously, ketamine is already used to treat depression in the UK. There are ketamine clinics where patients have an infusion of ketamine. They sit in the room, they have a drip, which lasts maybe 45 minutes, and then they go home. You know, there's nasal ketamine, which is also licensed, so people can sort of take that as a spray. There's very promising results with PTSD and MDMA, and some new results that should be published in the next year, hopefully, about addiction and MDMA, alcohol addiction. So that's a really, really interesting area, which I think will become mainstream, but probably at least 5 years from now. But you know, I attend the Department of Psychedelic Research at Imperial, so I sit in on the research group meetings sometimes. So, you know, these are the people spearheading the research, and they're saying, yeah, within 5 years, hopefully.
Perfect. Thank you so much, Dr. Cross.
Welcome.
And we'll move swiftly on to forensic psychiatry with Dr. Aslanyan.
Hello, hi, my name's Isabel. It's really great to see you all here. I'm just so happy that there's a society for budding psychiatrists, so you're choosing the right specialty. I'll just share my screen.
Yeah, perfect.
So I've got just a few slides. So I'm a registrar. I know you've had some consultants. I'm sort of earlier in my training. So I work in forensic psychiatry, so I'll just tell you a little bit about what that involves. So how to get there? So I've taken a more sort of straightforward route. So you just graduate, and then I did 2 years of foundation years, F1 and F2. And within that, I had a psychiatry rotation because for a long time I knew I wanted to do psychiatry. I didn't really know which type. And so I made sure my F1, F2 had a rotation. And I think most F1, F2 jobs do now. So that was good to sort of consolidate my interest. And then I went from F2 into core training. So you have to do 3 years of core psychiatry training. And it was in core training that I realized I wanted to do forensic. I had a 6-month job in a forensic unit, and I had a 6-month job in the prison mental health team. So that was going into the prisons every day and seeing patients. And yeah, those 2 jobs really made me think forensics is the one for me. Yeah, just ask questions at any time, don't have to wait till the end. So now I'm in the next bit, so I'm in the forensic specialty training. So then after the core training, where you try a little bit out of everything, then you choose your subspecialty. So I'm in that 3-year bit of specialty training. But there is a lot of more, and then after that you'll be a consultant. There is more flexibility in that. So between core training and specialty training, I did a year of a staff grade job. And people take on these jobs for as long as they like, really. But people do research jobs, people just extend their core training with these jobs by sort of trying out different teams, working out what they want to do. And it's quite nice because it's more 9 to 5. There isn't the sort of the training requirements, not the on-call rotas, a bit more flexibility. So it doesn't have to be like a conveyor belt like it sometimes feels in medical school, like tick, 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 next, next, next. You can do other things along the way. And I'm sure you know all about sort of portfolio requirements, but comm skills in particular, always number one in psychiatry, I think, through interviews that I've been through. Teaching skills, showing that you're doing teaching for students. Research, they always ask you about that kind of thing. Leadership, audit, QI, and presentations, and stuff like this, really. So, you know, if you're in a psychiatry society since medical school, you're much more organised than I ever was. So there you go. So this is where I work. So this is Froomside Forensic Unit. It's in Bristol, in East Bristol, near Fish Ponds. So this is sort of an aerial photograph in the snow. And so you can see each one of these is a ward. So you can see each one. So we have two sort of hospitals on site. We've got medium secure and low secure. So it's 80 beds and 30 beds. So quite a large forensic unit. And then we're split up into wards of about 10 patients in each ward. And then they've all got a little outside area as well. So they've got the gardens for each ward. So what is forensic psychiatry, before I sort of talk about everything else? So the main thing that we're looking into is where there's mental disorder and mental illness and there's a risk to other people. That's our sort of primary requirement. We wouldn't be having anybody who wasn't a risk to other people. They're quite complex patients, so we usually have a triad of different things that we see in our patients. So that's mental illness, that usually falls under psychosis. So we see people hearing voices, unusual ideas, usually paranoid, can be quite complex ideas, and sort of psychotic. Also traits of personality disorder. We see lots of people have really traumatic upbringings, and that gives them sort of personality traits like emotional instability or antisocial traits that have led them to violent crime or other sorts of crime. And also addiction. I can't think of many patients on my ward who haven't had substance misuse problems. So it's a sort of cocktail of all these things. And as we know, sort of early trauma is a risk factor for developing all three of these things. And that's what I think can be sort of disinhibiting for then committing crimes. So you usually see all three of these. Just to add, on our unit, it's all men. So 100, it's all men unit, apart from 10 female beds. And so it's quite unusual that we work with mainly male patients with a small female cohort. And we also have a 10-bed unit for 10-bed ward for people with LD, learning disability, or severe autism as well, who have committed crimes. So we have units that are high, medium and low. As I say, we have medium and low on our site. So that depends on their sort of behaviour on the ward and the crimes they've committed. And then high secure, there's sort of one for the south, one in the north, and then one in Scotland. So the sort of famous one is Broadmoor. That's our sort of local high secure unit for the south. So then within my training, I have to do 6 weeks at Broadmoor so that I have that high secure experience. We talk a lot about security because we are dealing with risk all the time, risk to others. So that usually falls under physical security. So you'd see locked doors, fences, that kind of thing, being the physical security that limits somebody's freedom and risk. And then relational security. So the good relationships that we build with patients and between staff and patients to patients, that protects people from committing crime. So if you think about why you and I don't commit crime on a daily basis, it's mainly because of relational security, because of the relationship that we have with one another, not because there's physical barriers to stopping us from doing it. And we talk about procedural security. So if we sign out somebody's a risk item, then we make sure that that risk item comes back, like a knife or something, if they were doing a cooking session, and sort of things being procedures around leave and things like that. So things I really like is that we have really long relationships with patients. I think lots of psychiatry services these days, there's a big pressure to discharge, sort of admit, assess, treat, discharge as soon as possible. Whereas with forensics, we have people for a really long time. It depends a lot on their sort of mental state and the crime they've committed, but we have patients that can be sort of 5 to 10 years. So a really long time, really long relationships that we can do therapeutic work through. Proper MDT working, we're lucky, forensic services as a whole, we're very well resourced compared to other psychiatry services. We have sort of psychology, OT, nurses, HCAs, psychotherapy, social workers and doctors. And I think it's to do with the funding of forensic services. It used to be through the Home Office, through the criminal justice route, and then it got transferred to the NHS. So yeah, we're very well resourced in terms of MDT working. And it feels like we all sort of contribute to patient care. And so you can really have those multidisciplinary discussions about patients. We also have GPs on site, so we have sort of a GP on site, which we don't have in other areas of GPs. And we have a really good sort of OT activity centre. So we have a sports hall, we have woodworking, metalworking, and patients, when they're with us, they can do sort of rehabilitative stuff like they can take GCSEs, they can do NVQs, they can do food hygiene certificates, certificates to work on construction sites. So lots of really rehabilitative work and learning new skills so they can make real changes in their lives when they leave us, and really sort of boost their self-esteem as well. Yeah, sorts of library, gym, IT and art room as well. So where do our patients come from? So we have a different set of sections. I don't know how much you know about sort of sections of Mental Health Act, but we have different sections to do with the criminal justice route. So our pathways onto the ward, lots of our patients come from prison. So if they were sort of arrested for a crime, they're in prison and somebody's noticed that their mental states, they're really unwell. And so then they have the prison mental health team would assess them just like somebody would in the community. And then if they're really unwell, then the equivalent of having admission when you're living in the community would be an admission to us instead of being admitted onto a general adult psychiatry ward. And they can also come from general adult wards, from PICUs, this is sort of higher risk psychiatric wards. People can be ordered from the courts to come to us. For instance, if they were having an assessment of their mental health in relation to a crime they've committed. They can come from police stations when they've just been arrested. They can be stepped down from high secure or medium secure, and they can also be recalled from the community. So when somebody's discharged from us, it's not sort of like a full discharge. If there's an escalation in their risk to others, they can be recalled to us by law. So that's sort of resectioned. So yeah, different things. And so we have these things called sort of hospital orders that people come to us on. So if we sort of assess their mental health at the time of the crime and just afterwards, and we feel that their mental disorder contributed to the crime and they're still mentally unwell, then instead of having a sentence in prison, they come to us on a hospital order, and then we're responsible for their treatment and rehabilitation going forward rather than a prison sentence. So quite a different, they call it a diversion, so they're diverted away from prison. So just to give an example, this was a case that I watched through court. So it was sort of a typical case really. So this man in South Bristol, he was having a psychotic episode. It sort of made the news, and the BBC stab accused thought aliens would kill his family. So this is really a sort of textbook, sort of quite extreme end of things, but just to sort of give you an idea of the kind of thing. And so he was going through a very stressful time. This triggered a psychotic episode. He put on his rollerblades, roller skated through South Bristol with a knife, and attacked people. Fortunately, nobody was severely injured. Sort of there was a sort of psychological impact. So then what would happen? And then he was arrested. He was sent to prison, and while he was on remand, the prison mental health team noticed that he was psychotic, that he was really mentally unwell. And so then what happened? He was transferred to a forensic unit for treatment, and during that time he was also preparing for his trial and sentencing, and so he had a psychiatric report, and then we'd write the psychiatric report saying about what happened at the time of the crime and how he is now, and we'd recommend a hospital order for that person. So this person had a specific set of circumstances that he was cleared of his charges because for the reason of insanity. So that's a very particular legal defence that he did fulfil with his mental state. So just to talk a little bit about my day-to-day work, it's not all sort of press-hitting cases that we deal with, but we do a lot of court reports, so they're commissioned by solicitors or by the court, and so they can be patients within the unit or patients in prison, and then we go and visit them and we do an assessment of them, and we read through all their notes and we make our recommendation at what we think should happen for that person. I've also recently done a parole board report, so somebody with a mental disorder sitting in prison waiting parole, and they want a psychiatrist's opinion about planning their release. Access assessment, so get referrals, so it's gatekeeping, saying should they come to us or not. Dealing with incidents, we do have incidents on the ward with violence or verbal aggression, and sort of thinking, how do we, what happens next for that person, and the ward dynamics. Risk assessments, we're constantly thinking about risk in a way. Ward dynamics, we're thinking about how different patients get on, because when people have been there for sort of 5 to 10 years, and there's lots of relationships between different patients as well. So we've got to be thinking about, if we're moving a patient from one ward to another, who gets on with who, where is their safeguarding concern, etc., etc. I facilitate a patient group, so I run a hearing voices group, so it sort of supports people who have hearing voices experiences, and peer support, so it's quite varied. I do teaching, we have medical students come and join us, we have junior doctors, I do supervision. I do a ward supervision group, so that's for nurses on a particular ward, and they can talk about things that are going on the ward at that time. I'm doing a master's in medical law, so I'm doing that 1 day a week, so there's lots of opportunities to do things like that. And then that legal side really sort of then taps in with the forensic psychiatry, because things like expert evidence that I'll be doing in the future. There's also sort of the general inpatient psychiatric care, that's sort of like prescribing, patient reviews, that you'll get in any sort of inpatient psychiatry environments. There's lots of similarities between the general adult ward, but then there's some things that are very specific to forensics as well. And treatment, rehabilitation, discharge plannings, there's lots of planning for those sorts of things. Again, working with probation sometimes as well, and police officers. And we have lots of tribunals, so anyone who's living under a section of the Mental Health Act has a right to a tribunal, so we do lots of tribunal reports and managers' hearings, and we go through all that as well. And that's sort of in front of a sort of very small, it's like a small court really, where the patient can challenge their section and we have to defend the section. So I just thought I'd include, this is one of my last slides, just about the best bits that I find why I chose forensics, is the long relationships with patients. That's where I really get a lot of satisfaction from my work. I find that for some people, they really like the liaison of meeting new people all the time and sort of seeing them for a short time and then not seeing them again, and they like that, you know, they like that turnover. Whereas I'm somebody, I like to really thoroughly know about my patients. I want to know everything about their lives, and then see them through their admission over years. So if you like that, then you'll like forensics. Really an opportunity for life-changing admissions. That's really the best bit, when you see somebody really turn their life around. Again, in sort of general adult psychiatry, sometimes they're discharged just as soon as they're well, and then they do all the work in the community, which is also really fantastic. But in forensics, you see that change from sort of probably sort of the worst point in somebody's life is when they've committed a horrible crime, and then, you know, seeing how they can rehabilitate and reintegrate into society with their mental disorder is great. Court work, I really enjoyed court work. We sort of sit in court, we do sort of expert evidence, court reports, and like sort of the legal side of things, really interesting. Proper formulations of patients, really understanding why they have a mental disorder and why they've committed the crime and how we can stop it happening again. Yeah, and just that time to really think about the patient and get to know about them. Working with the MDT, I really love working with my psychology colleagues, psychotherapy colleagues, and really thinking in that way as well. We all learn off each other, and that's great. And I really like the sort of ethical legal dilemmas that comes up. I mean, as a society, if somebody like that man in the press articles, you know, he believed aliens were going to attack him, and then he's doing that to somebody else, how do we decide as a society what to do with that person? Yes, he's done a bad thing. He didn't really understand what he was doing. He was working under a strange pretense. You know, is the forensic unit the right place? In lots of countries in the world, they don't have forensic units. These people would be in prison on a mental health wing, which is very different to what we provide. So, you know, the answer that we have in the UK isn't the answer everywhere. And I think that's a really interesting sort of dilemma. And that we really embrace complexity. I think there's a temptation that we sort of think about, oh, this person has a mental disorder, and, you know, step 1 diagnose, step 2 treat, this kind of thing, whereas we really think about all the complexity going on for that person and sort of think about all the different ways we can approach it. So I've got the not for everyone bits, because they're sort of bad bits, but they're different. So yes, patients, victims, we have some really tragic cases, and that's something that we have to think about when we're working with people, and that you're building a therapeutic relationship with somebody who's potentially done something really awful, and thinking about, you can sometimes read the patient's sort of impact statements on their victims, and can be really heartbreaking. So, but we have lots of supervision. So we have a forensic psychotherapist who comes in, and we can talk about anything that's on our mind. We have supervision around those things. We have angry, rude patients. I think some people like a well-behaved patient who's going to say thank you all the time and do what you say. No, we don't have that. We have patients who can be quite angry and rude and violent sometimes as well. But yeah, I think because we think about risk so much, we're really prepared for that in a way that other services, when there is that sort of situation, it's not really foreseen. Whereas, we can guard against it in a way. We have more time in front of the computer maybe than other psychiatric specialties, I think, because of that sort of turnover of seeing new patients all the time, whereas I spend a lot of time, if I'm doing a court report, I might be sent by the solicitor, might send me like a 130-page bundle about that person, and so I'll be sitting there reading all about the patient's background. So yeah, we do a lot of reading and going through records, and requesting old notes and going, but you feel a bit like a detective when you get this pile of notes delivered from the other side of the country to read through and put in your report. So yeah, we do more time for the computer. Slow progress. So obviously we have lots of patients who have really, really slow progress. It's not all this sort of life-changing admission stuff. It's slow work, slow stuff, but we've got time to do it. And then of course you get no progress. So we have people that are like really treatment resistant, and the progress they're making is sometimes hard to know if there is any. But there's, we have both. We have all of it going on. It's not just all one or the other. Medication side effects. I'm sure anyone going to psychiatry needs to be aware of the medication we prescribe is far from ideal, and you can see the effects of that and feel like, oh, we're weighing up the good and the bad bit here. But when somebody's there for a very long time, and we use a lot of antipsychotics because everybody has psychosis, you can really see the side effects that they have on people, as well as the really therapeutic benefits they have. So yeah, that's that. So yeah, I kept my things short. I thought we'd have time for questions, and I know people will probably want their dinner as well. But yeah, I'm very happy because I think it is mainly Bristol students. If you want to come and spend a day in forensics, then get in touch, or any other questions, let me know. But yeah, choose psychiatry generally, and forensics if you fancy.
Thanks so much, Sibel. I think Wumi's got a question. She says, can someone be held in hospital indefinitely if on a hospital order?
Oh, well, yes, they can really. So with a sort of prison sentence, you get your sentence, and then regardless of what your risk to everybody else is, or regardless of what you think of your crime, you get released on your release date. Whereas with a hospital order, we have to prove to a mental health tribunal that it's safe to discharge you. So we have the sort of tribunals where we're sort of defending the section, and then we have a tribunal where we have to persuade them that the sort of arrangements that we've made in the community are safe enough to discharge them. So yeah, hospital orders are longer, but they can be shorter as well. So it can be quite controversial about sometimes when it's shorter, when we think their psychotic episode has been fully treated, and they wouldn't reoffend in that way, then actually it can sometimes be shorter as well. Had anyone even heard of forensics? I was just reflecting when I was writing this. I don't think I'd even heard of forensic psychiatry until sort of like F2 maybe. So it's we're quite niche, we're quite small compared. I think it's like 5% of all mental health patients. So we're quite small, but really interesting, especially if you like sort of the legal side of things. Yeah.
I want to ask, because the patients don't really have a choice as to who they're, because if they're staying in an inpatient ward for like 10 years or so, they don't really have a choice on who's staying with them, their roommates and stuff. Does that cause a lot of problems?
So no, you'll find across psychiatry that people don't really have roommates. It's most psychiatric wards now, it's sort of, you go into like a corridor of rooms, and so everybody has their own bedroom or with an ensuite, and then so it's more sort of like who's in the neighbouring rooms. But then I suppose, as you say, that, you know, who's the other 7 patients on your ward. But people do move through the wards, so as there's about sort of 10 wards at Freemside, and so one of them would be sort of new admissions, more mentally unwell, maybe more agitated behaviour, and then when things have settled, then they move to a longer term ward, and then they move into a rehab ward. But yeah, the patients do get to know each other quite well, and then they know each other from, say, the football. So they're like, oh, I know so-and-so from football, or I know him from the therapy group. Well, none of that's happening at the moment because of COVID, but yeah, they sort of know each other that way anyway. But yeah, if there was a safeguarding concern, then we do have a duty to sort of separate people. But no, they don't know who's going to share the ward with them. Yeah.
Isabel's asked a really interesting question. Do you ever find it hard to be objective when treating patients in regards to their crimes?
Yes, I think that is a concern, and it's something we all have to be aware of in forensics, that we continue to be professional and give them the same standard of care regardless of what crime they've committed, because that's what they need. They need really good standard of care in order to be rehabilitated and for their good and the good of society, really. So I think that's when supervision becomes really important, and I think that's in every area of psychiatry. You need really good supervision to go to them and say, you know, this patient's really annoying me, like whether it's, you know, because of their crime, or whether it's because, you know, it's the 10th time that they've come into A&E that week. You need to have somewhere to take those feelings of like, that's really irritating. I've put so much into this person and now they're shouting at me. So that you can take it there and then not take it to your patient, because if you take it to your patient, then you're falling into a relationship that they've had with so many people in their lives, and that is ultimately damaging to them, and you're being drawn into a role that they've played so many times, whereas you need to give them something new and be yourself, not the role that you're being pulled into, if that makes any sense. Yeah, and also when you do get to know somebody and that know about all their like early years, I think knowing about somebody's childhood and the traumas they've been through, and a real understanding of why they committed the crime, that really helps your compassion and your empathy. You know, you read somebody's childhood and you just think, God, this person didn't have a chance to have a normal life. They didn't have a chance to not offend.
And she's asked as well, do people ever end up in your care where it ends up being decided that they don't actually have a mental health illness?
Yeah, so we have people that are sent for sort of an assessment, and then we decide that they don't have a mental disorder and they get sent to prison. We say that they don't fulfill the criteria for a hospital order. But yeah, it's we have, so for somebody to have a hospital order, one of the psychiatrists at the unit that they're going to has to agree for them to come. So we can't just get sent a patient because somebody somewhere says that it should go to a forensic unit. It has to be somebody here saying we'll take them. So that makes it less likely that you'll then disagree with your own assessment.
And Edward's asked, do victims ever get in contact with you, or do you ever need to get in contact with victims?
No, we don't really have anything to do with the victims. They have victim liaison officers, VLOs, and we have social workers within our teams, and they liaise with the victim liaison officers. But no, we don't have sort of direct contact with victims. We might contact the patient's family to learn a little bit more about them, about their mental disorder. And we sometimes, as I say, we get these court bundles and we might get the victim impact statement. And so that's something that they've written for the court, not specifically for us, about what impact the crime has had on them. So that's why we know mostly about how they feel about it.
Well, thank you so much for speaking to us, Val. That was really interesting. And thank you to everyone that's come and joined us today. It's been really, really lovely hearing from all the different doctors and their specialties. I know some of the other speakers have run off already, but thank you, Dr. Gupta, as well.
Oh,
Everyone.
thank you. Thanks.
And if you have any questions, please email any of the email addresses, or you can email Bristol PsychSoc and we can liaise with the doctors and get back to you.
Perfect. Thank you.
Thank you. Have a good evening.
Have a lovely evening, everyone.
Bye. Bye.
Bye.